So I want to say thank you all for coming this evening and for your desire to learn and empower yourself with your healthcare. My name is Rose Ryder, and I'm in business development at Long Beach Medical Center. And as I look around this room, it is just fantastic to see so many here physically, but also those who are here virtually as well. We just want you guys to know that any questions that you have will definitely be answered. You just submit them through the chat box. All right, so it is with gratitude that I introduce you to our speaker this evening, Dr. Mark Lee. Dr. Lee serves as Medical Director of Electrophysiology at the Memorial Care Heart and Vascular Institute at Long Beach Medical Center. And he's also in private practice at Memorial Cardiology, which is in Long Beach as well. Memorial Care is very fortunate to have him in a leadership role as medical director. His education, his training, his experiences from private practice, his collaboration with other electrophysiologists and cardiologists, his discussions with his patients, and I know some of you are here this evening, and his willingness to be here on a Wednesday night. It all speaks to who he is as a leader and as a person. So it is with great desire to welcome him this evening and sit back, enjoy. I have no doubt you're going to be walking away with some things that are new to you and that you can definitely implement in your own healthcare. So let's tell the other room that our speaker is on now and give a rounding applause to Dr. Lee.
All right. Thank you very much for attending this session. I'm really excited to talk about this topic. See a lot of friendly faces. I got to be on best behavior because my wife is actually here. So I'll be in tip-top shape today. And so I'm going to be talking about atrial fibrillation. It's a topic that I'm really passionate about. And I always joke with my wife, I spend more time living in the left atrium than my own home because it's all I do. And fortunately for me, it's a topic that I enjoy talking about, and I feel like there's a lot of misinformation related to it. So hopefully you came with a lot of questions, and I'll get to the nuts and bolts about what this rhythm entails, from prevention all the way to a procedure if you're interested. I don't have any disclosures for today. So atrial fibrillation is an irregular heart rhythm originating in the upper heart chambers called the atria. And when you have this rhythm, it prevents blood flow from being pumped efficiently throughout the rest of the body. So how many people here have heard about atrial fibrillation or know of someone with it? Yeah, it's probably the majority of folks, right? Believe it or not, 25% of us will have AFib sometime in our lives. So by the time we reach 80 years of age, 25% of us, so 1 in 4, will have AFib. So it's not uncommon for multiple family members to also have AFib. Not because it's hereditary, it's not something that's usually passed on, it's just a very common rhythm. So if someone has palpitations and has certain risk factors, it's a rhythm that I'm always looking for. So just to get some basics out of the way, atrial fibrillation is the most common sustained heart rhythm disorder. 70% of patients with AFib are between the ages of 65 to 85. Many hospitalizations related to atrial fibrillation, close to 1 million encounters per year. Atrial fibrillation is not the cause of death, but a lot of patients with comorbidities who pass away have atrial fibrillation as a contributing factor. And for me, the parts I really want to emphasize to patients is that there's a 5 times risk for having a stroke and 5 times risk for heart failure if you have AFib. So these are reasons we care about it, even if you're not symptomatic from the rhythm. AFib is an expensive diagnosis. So if you see the left column, that's a patient without AFib. Annual hospital costs, outpatient costs, medications, it amounts to about $10,000 per patient per year on average. You take that same patient with atrial fibrillation, their hospital costs go up, their outpatient costs go up, and it's an $8,000 or close to $9,000 difference of more encounters, more expense. So you can see that it's places a heavy burden on our healthcare system. $37 billion of incremental costs for patients having atrial fibrillation in 2020, and now that we're in 2024, that number is going to be even higher. So prevalence means how many patients have the diagnosis of atrial fibrillation. So in 2010, it was about 5.2 million folks. I would say currently 2024, the estimate's anywhere between 7 to 8 million. By 2030, it's going to be much higher, 12.1 million. Incidence is how many patients are diagnosed with atrial fibrillation per year. So by 2030, it's going to be 2.5 million folks are going to be diagnosed with this on a yearly basis. So it's a very common problem that we deal with in the US. And part of the reason is that, patients are just living longer. Even 30 years ago, we didn't have a stent. We're talking with a patient earlier who's going to have an angiogram. Back then, if you had a heart attack, you just wait it out and you let nature take its course. You either get bypass surgery, open your chest, and then over the past 20 to 30 years, stents really took off, and now you don't have to get your chest open to treat your heart blockage, and so patients are living longer with heart disease. And diagnostic tools are improving too. We'll talk later about the Apple Watch or some of these devices that are detecting atrial fibrillation, and we'll talk to see if that's something worthwhile to get. So on the left diagram here, you see a normal heartbeat. This is actually the right side of the heart. This is the left side of the heart. These two top chambers are the atria. The bottom chambers are the ventricles. We call that the sinus node. So top, bottom, top, bottom. And here, that's the top chamber. The tall spike is the bottom chamber. So atria, ventricle, atrial, ventricle. So it's the regular rhythm. When you have AFib, it actually originates from the left atrium. That's where I spend most of my time. And you can see the electrical waveforms are chaotic. So the whole top chamber is just fibrillating. And so you can see here, this bottom little artifact-like waveform, that's the atrial fibrillation. And you can see the tall spikes represent the ventricles. It just happens at random. You got a long space followed by a short interval, long interval, short interval. So that's called irregularly irregular. So from an EKG, it's pathognomonic, meaning we know for sure whether or not you have atrial fibrillation from a simple test. So once again, in EKG, there's no question about it. If we see this in the office, in the ER, you're diagnosed with atrial fibrillation, and from there, we got to see what your risk factors are and determine whether or not you need additional therapies or a game plan. You can see here, irregularly irregular rhythm. So all the long interval, shorter interval, longer interval, shorter interval. So this is a really important slide from my perspective. Any patient with atrial fibrillation that I meet, I try to categorize them into one of these buckets. So the friend who has AFib, who's had multiple ablations versus the friend who's on medication and the AFib doesn't come back, they probably have different atrial fibrillation. So it's not an apples-to-apple comparison. But one way to determine that is the duration of AFib. So if you're in early stage AFib, we call that paroxysmal atrial fibrillation. So that's AFib that spontaneously goes from AFib to normal rhythm within 7 days. So in the early stages, a lot of patients will come to me and say, I feel these palpitations, I feel winded. Anytime you come to the office, your EKG is normal. So it's very frustrating. And patients get diagnosed with anxiety or panic attacks for decades. And that's because you go to the office and your EKG is always normal. These AFib spurts in the beginning can be a few minutes long, a few hours, and by the time you go to the hospital, you're back in a normal rhythm. Early persistent is when that paroxysmal stage transitions to greater than a week at a time. So the AFib lasts for more than 7 days. So then you're in early persistent. Then you go to persistent, where you're in atrial fibrillation for up to a year at a time. So by the time it's persistent, we know you have AFib because when you come to the office or you go to the hospital for a different reason, let's say you went there for belly pain, you get an EKG, you're going to be in atrial fibrillation by this stage. So a lot of times AFib is diagnosed incidentally during this stage while you're getting treatment for something else, getting your cataracts, getting a colonoscopy, your prostate exam, for example, an EKG will show, oh, there's an irregular rhythm, call your cardiologist. And then the point we never want to get to in 2024 is long-standing persistent. It's basically where you're in atrial fibrillation for years at a time. And that's where things get difficult. I really want to meet patients in the paroxysmal stage because all the tools are available to us during that stage with the highest chance for success and maintenance of normal rhythm. So it's not the best analogy I can come up with, but I would say it's like stages of cancer. Paroxysmal atrial fibrillation is like stage 1. You have a chance. You have a chance to get that cancer in remission where it doesn't come back. Same thing with AFib. By the time you're here, I'd say it's like stage 4. Whatever you throw at it, the AFib is going to be very difficult to treat. So, how quickly does it transition from stage to stage? Let's say you have your first noticeable episode of AFib. As early as 2 years, that can develop into paroxysmal atrial fibrillation, where it continues to come and go. And then from there, another 2 to 3 years transitions to persistent atrial fibrillation. So the window is pretty small. Within a few years, you may transition from paroxysmal to persistent atrial fibrillation. So if you feel like you have atrial fibrillation, then you really have to be, an advocate for yourself, because oftentimes the doctor is going to be very busy. If your EKG is normal, they're going to say you don't have AFib, but that's not true. You may have paroxysmal atrial fibrillation that's just difficult to capture. So you really want to be an advocate for yourself if you feel like you have this type of scenario. So let's talk about some risk factors for AFib. The left side are what we call the non-modifiable risk factors. We're all subject to father time. We have no choice. So we're all going to get older. The family history, our genes, they're given to us. We can't choose that either. Heart disease as well, sometimes it's genetic. So these traits are often unmodifiable. But yes, the older we get, the more likelihood of getting atrial fibrillation. If you have heart disease, then yes. Like I said earlier, it's usually not a genetic phenomenon. So family history in this sense means more of other conditions that are passed on, like diabetes or other traits. This is the circle that I want to focus on, is the lifestyle factors. We all have a choice here to try to do something about the risk factors. So sleep apnea, obesity, alcohol consumption, smoking, caffeine consumption, stress. All of us go through, or maybe the alcohol smoking, some folks are lifetime non-smokers or drinkers, but these are, modifiable traits that if we curtail, it's just good in general. I would say these same risk factors show up for heart attack conversations and for other health issues like diabetes as well. But for atrial fibrillation in particular, you really want to look out for these lifestyle factors. So one of the myths I want to put down is that atrial fibrillation is not a life-threatening rhythm. I think a lot of patients, when they feel their heart racing, their primary concern is, am I going to drop dead? Or am I going to get a heart attack? And that is not the case. It's not a life-threatening rhythm. You're going to feel symptomatic because when you're in atrial fibrillation, your heart rates can be very fast. So some folks can get heart rates above 200 beats a minute. It doesn't matter what the rhythm is. It could be a normal rhythm. If your heart rate is at 200, you're going to feel lousy. So that's where the symptoms are very prominent. You have rapid atrial fibrillation. Also, it's not going to cause a heart attack. So I'm an electrical heart doctor, so I always tell patients I'm an electrician. If you have a heart attack, you need a plumber. So I know a lot of you have a plumbing cardiologist, and that involves the vessels in the heart, which are located outside. And if you get calcium buildup or cholesterol buildup, it decreases the blood flow, and then that part of the heart can die. So that is what a heart attack is. Atrial fibrillation is an electrical issue. The diagram earlier, we saw the electrical waveforms just meandering. It's a different problem. So even in your house, you could have the lights not working, but the plumbing is fine. The faucet turns on. Vice versa. Same thing with the heart. But we do care about atrial fibrillation because certain important diagnoses or outcomes are truly affected by atrial fibrillation. One of the most important being stroke. So there's a 5 times risk of developing stroke if you're in atrial fibrillation and you're untreated. If you're treated for it, we can make that risk essentially 0%. You're going to get 3 to 5 times risk of heart failure. Now we're getting pretty solid data that atrial fibrillation also contributes to dementia and then possibly even kidney failure. So let's talk about symptoms. The symptoms can be varied from patient to patient. I never say never with a symptom related to atrial fibrillation. It could be nausea for some folks. It can be lightheadedness. It could be chest pain. I would say the most common symptom is fatigue. Patients say they feel tired, they feel winded when they are running errands or tending their garden. And a lot of folks kind of contribute or attribute that to just getting a year older. So a lot of patients will say, I thought I was just getting older this year. So it can be something that kind of just creeps up on you over time, especially if you have chronic atrial fibrillation. But I would say fatigue, shortness of breath when you're moving around and doing activities are the most common symptoms. So, what's the good news? Well, like we talked about, we can do some lifestyle modifications. Number one being blood pressure. So if you have high blood pressure, we should be aggressive in treating that for many other diagnoses, but atrial fibrillation for sure. By having hypertension, your AFib risk increases by 50%. So that's a big deal. So what is hypertension? It doesn't actually involve the heart. It indirectly involves the heart. So hypertension affects this vessel called the aorta. In a normal thickness or a normal tensile aorta, the heart doesn't have to work too hard. But let's say the aorta is very stiff and you have high blood pressure, then the left ventricle, this is the workhorse of the heart, has to squeeze extra hard. And the heart is a muscle. It's just like any other muscle. If you use it too much, it's going to get bigger and thicker. And so the muscle will respond by thickening. I don't know if you could appreciate the difference, but this ventricle is just a little bit thicker than this one here. Tobacco causes what we call oxidative stress. What is oxidation? It's essentially rust. You're rusting the arteries, you're placing rust in the heart muscles. Part of the reason why your arteries stiffen and get hypertension. So oxidation and tobacco use is definitely a risk factor. Active smokers have a 2 times risk for developing AFib. And if you quit smoking, you get a 36% risk reduction. So there's immediate benefits. Exercise is great for many conditions, but for atrial fibrillation, if you just do moderate exercise, and moderate is just walking 4 to 5 times a week for even 30 minutes at a time, your AFib burden can reduce by 50%. And for every increase, 1 point increase in your BMI, so that's a marker for how much you weigh based on your height and your weight, you get a 4% increase risk for atrial fibrillation. So if your BMI changes from month to month, especially over the holiday seasons, then your AFib risk will go up. So here, let's look at a global map of the prevalence of AFib. We talked about prevalence being how many patients have atrial fibrillation, and we're way in the lead. Yeah, nothing to brag about here, but US is number 1. Canada joins us too, I guess, huh? But Europe and the Asian countries are doing a little better. But on the whole continent, or the whole planet, is in that kind of moderate range of having AFib. Wherever you go, you're going to find AFib. Let's look at another map. This is the obesity map. Once again, US is really good. And so you can see that, my point in showing these 2 maps is that it looks pretty similar. So obesity goes hand in hand with a lot of these cardiac conditions, especially AFib. Kind of an interesting side-by-side comparison. Sleep is really important. Many studies show that on average, most folks sleep about 6.5 hours, but sleep deprivation can increase your risk of AFib. probably because it increases stress, it increases high blood pressure. There's just a lot of downstream effects if you don't get good sleep. But there is one condition called sleep apnea, and it's obstructive sleep apnea, OSA, and that increases your AFib risk by 5 times. And why is that? It's because when you have sleep apnea, you're basically not breathing for minutes at a time while you're sleeping. You're putting immense stress on your heart. So unfortunately, the solution is a CPAP machine, and many, many patients say it's very difficult to wear this all night. It really is difficult. But you want to find something that works for you. You know, this patient doesn't have the full face mask, kind of just more the nasal pillows. Now there's some dental guards even that can help. Sometimes there's also like a pacemaker device that might help. So something to definitely consider. Any patient with AFib, we always work up sleep apnea, because if this patient has sleep apnea, it's potentially a reversible condition. If we could treat the apnea, the AFib might go away. So we want to really look into this. And then stress. Yeah, we can't minimize stress. So being sad, being angry, feeling anxious, these all increase your risk for AFib by 4 to 5 times, believe it or not. There are actually studies showing this. So this is not something that's more of a soft evidence. There really is hard evidence to support this. So most folks are 85% less likely to be in atrial fibrillation when they're happy. And I'm pretty sure that this baby does not have AFib. And then there are certain triggers for AFib, one of them being alcohol. We actually have a condition called a holiday heart. So, you know, Super Bowl is coming up. Some folks can go on some binge drinking, and then the following day, they get atrial fibrillation, their heart's racing. We call that the holiday heart. Energy drinks are very common, like the Monster drink or Red Bull that college students drink to do all-nighters studying for their exams. We're seeing 20-year-olds have AFib nowadays, and we're proving that because there's the Apple Watch, Fitbit devices. And then caffeine. Caffeine is more controversial, actually. We feel like caffeine is probably a risk factor, but now there's some studies saying maybe not. So that's good news for me, because I am a coffee drinker. So let's talk about treatments. So 2 main things that we want to think about for AF therapy. One is for symptomatic patients, we want to make them feel better. And then the non-negotiable is stroke prevention. We just don't want anyone developing a stroke from atrial fibrillation. So if you have symptomatic AFib, we can do medicines or even a procedure to treat the rhythm. Do you have to do it? No. Some patients say they tolerate it. They say, you know what, I can just control the amount of activity I do to not experience symptoms. So instead of running, they'll jog or walk. And they say, you know, I'm happy with that. So in that type of patient, we don't have to do anything other than just monitoring their AFib on routine visits. But some patients say, you know what, I don't like the fact that I can't be active. I feel tired when I'm working in the garage and doing exercises. So they want to have some therapy options. We'll talk about some of these moving forward. And then everybody needs to be considered for stroke prevention. So there's a scoring system that we use that we're going to talk about later. And the therapy for stroke prevention is a medicine category called anticoagulants. So it's the Eliquises, the Xareltos. I'm sure you've seen the commercials of people walking on the beach getting these commercials for Xarelto and Eliquis. So we'll talk about that too. So earlier on, we focused on the right side of the heart. That's where the sinus node comes out and goes top, bottom, top, bottom. But here we got a more detailed view of the left atrium. You see these 4 circles here? These are the opening of the veins from the lungs that drain back into the heart. So these are the pulmonary veins. In the next slide here, we're going to look at the back side of this structure. So now you see these veins here? So this is the left atrium, and these are the pulmonary veins. And you see these starbursts? So these are the triggers for AFib. AFib actually originates not in the heart, but in the pulmonary veins. So whoever found this out is really remarkable to even think of looking here. But this was discovered 20 years ago, I guess close to 25 years from France, Bordeaux, France. There was 2 doctors who discovered that AFib is originating from these areas. So the early stage AFib, if you remember, is called paroxysmal, where it comes and goes. We just have to treat the triggers. This is all we need to do. When you transition to persistent AFib, you have to care about the triggers and then also the perpetuators. See all these little rotors? The heart just develops rotors where it just wants to continue to meander and meander. And what happens is there's a saying that AFib begets AFib. Once you're in AFib, this chamber stretches, gets larger, and then the waveforms have more room to travel. And as the AFib gets longer in duration, then the heart stretches even more. So if you've ever had an echocardiogram, you're going to see that patients with atrial fibrillation have a dilated left atrium. So if you've read your echo report and you see that your left atrium is dilated, that would be a risk factor that you might have atrial fibrillation. So let's talk about some therapies now. So in 2024, the most common procedural solution is called an ablation. So ablation is just an umbrella term where we use a tool like radio frequency, which is a burning approach, or cryoablation, which is a freezing approach. The goal is the same, is to kill tissue in a very specific area on purpose. So it's like grilling a piece of steak. You're trying to create char or the grill marks. The grill marks prevent electrical signals from going through. So it's not a physical barrier. You're just trying to char the tissue to the point that you get these scarred tissues so that the electrical signals are trapped. So we talked about these pulmonary veins as being the triggers for AFib. So if we use radio frequency, I'm just going point by point around the vein like a paintbrush and just creating that char. So we go make circles in each of the veins, and then the triggers are trapped inside those veins so that your normal heart rhythm can take over. With cryoablation, it's a balloon shape, and the whole top half of the balloon freezes. So we call this single shot therapy. You just wedge the balloon, which is a appropriate shape for the veins, and you can see that with a single shot ablation, you get that entire pulmonary vein ablated. So ablation is a procedural approach. If we see you during the paroxysmal stage of the rhythm, which is the coming and going stage of AFib, I quote a first procedure success rate of 90%, which is really good. We never use the word cure for AFib, just like stage 1 cancer, an oncologist will not say the word cure, but they'll say the cancer is in remission, it hasn't come back, it's being well treated, let's continue to monitor. Same thing with AFib, but studies are now showing that we can go decades without AFib coming back if we treat it early enough. The problem why you hear that ablation is ineffective is because we see patients too often during the persistent stage of the rhythm. Their AFib is already too advanced. In those patients, automatically my conversation shifts to, we may need to do this more than once. And that's because once you have very advanced AFib, you're at risk for different types of rhythms. Your chamber is very large, your chamber is very thick, so it's hard to get a robust lesion with one attempt. So who wants to see an ablation? This is an actual ablation. We use a paintbrush tool and we're creating the veins here. So that's the left upper vein, this is the right upper vein. So we're actively in the heart right now and creating a computer model of the heart. We got the right lower vein, the left lower vein. And so this patient is in atrial fibrillation. You see all the colors are chaotic. This should be just bright purple, but this person is in AFib. So this takes us about 2 minutes to create using that tool. And so this is the before. And what we do is we target the veins. We talked about ablating the veins. And then afterward, you see this. So this is the after now. We're showing that there's a clear barrier. You see that? There's a clear barrier. The purple is all healthy tissue. This patient is now in normal rhythm. And the red means electrically silent. So the AFib triggers, which are present in the veins, can no longer escape into the heart. So this patient is going to get a great result. 90% effective with one try. This is the front side of that same chamber. And you might ask, what's this structure right here? It's called the esophagus. That's where the food goes down. The esophagus happens to be right behind the heart. That's actually the most feared complication of an ablation. We do not want to make a connection from the heart to the esophagus. So we're monitoring that the entire time. So now here's the after. A lot more clean, there's clean barriers, and the AFib signals are trapped in these veins. Any questions about that? Yeah.
So, you're saying there's no difference between the air and the electric ablation?
One freezes and one burns. It truly is operator preference. Some operators prefer radio frequencies, some prefer cryo. We do both at our hospital. So there's no better or worse. It's just a comfort level of the operator, whatever they're trained on. And then in 2024, we got a new modality coming out called pulse field ablation. You're gonna read a lot about this year. Two major vendors just got this approved recently. So you're gonna read about it, but we've figured paroxysmal AFib out. No matter what new modality comes, the existing ones already work really well. But it's just an additional tool in our toolbox. So once it comes out, yes, we will do that too. Mm-hmm. Yes.
So where's the pulmonary vein here in this photograph?
All the reds here are the veins, yeah. So these veins are draining from the lungs back into the heart. So it's the lungs are oxygenating your blood, and then it's delivering the oxygenated blood back to the heart. That's what its purpose is, but it also is the area where AFib originates. So now we're seeing a radio frequency ablation. So I'm using this little tool to actually burn the heart, and you're gonna see dots form as I'm ablating. So here's a little gap right here, and all of a sudden you're gonna see a lesion. So we talked about ablating the veins, but if you have more persistent AFib or more complex AFib, sometimes I gotta do additional ablations. This is called a floor line, where I'm connecting the bottom veins. We're just creating more barriers so that the AFib signals have something to collide with. So you can see that it may be difficult because we have to watch out for these other collateral structures like the esophagus. So sometimes we have to dance around the esophagus to make sure we're not heating it too much. So there's, we don't know until we're inside the heart where the collateral structures reside. And so for chronic AFib or advanced AFib, this is oftentimes the approach that we're looking for. We want the entire backside of the heart electrically silent. So you can see it's more work. We rather treat you during the paroxysmal stage where it's just very focal. So how do we monitor AFib? Well, if we want long-term monitoring, we might offer a chip here called a loop recorder. It's a little incision that we make, and it's an injectable tool that we could even do in the office setting. The battery lasts anywhere from 3 to 5 years. So during that entire time, I will know every single heartbeat, what it's doing, and where you are at all times. We don't follow you. But the advantage of this is that we actually give you a little device, or the vendor gives you a device that you put next to your bed. And if you truly have AFib, your monitor while you're sleeping will transmit that information to our office. And so we will have a beat-to-beat analysis of, oh, this person's in AFib today. And that actually changes management. We may say, you have to be on blood thinners now. We have proven AFib. I'm sure you recognize the Apple Watch. The Apple Watch is excellent. The downside is it's not checking for AFib all the time. If it did, the battery would be depleted in a matter of hours. So it only checks once in a while. So even if you have AFib, it may not tell you you have AFib. The Cardia device is very popular too. You just put your fingers on this device and it gives you a EKG recording. The Cardia is great as well. It's just that you have to be intentional. You have to force yourself to check your rhythm. Whereas the Apple Watch is something that might automatically alert you. Did you have a question?
So the Apple Watch tells you you're in AFib.
Yes.
What would you do?
It depends. So if you have symptoms and it bothers you, then we can give you therapies or offer therapies like medication or even an ablation. At minimum, we should talk to you about stroke prevention and being on a blood thinner if you qualify. So the diagnosis is important.
But if you're on blood thinners, you still get this indication of AFib.
That's right, blood thinners. So the question is, if you're on blood thinners, does the watch matter? It still does. The blood thinner only not only, it protects you from stroke, but it doesn't treat the symptoms. So the Eliquis, the Xarelto is not going to make you feel better at all. So this is an Apple Watch tracing. It's just like an EKG essentially. It's a modified version of the EKG. It's not as accurate because we don't get all the leads, but it's pretty good. If you sent this to me, I can confidently say that you have atrial fibrillation, and I would talk to you about management. So to summarize the first part of the talk, AFib is the most common disorder in the US, or rhythm disorder in the US. Most common symptoms are fatigue, shortness of breath, exercise intolerance. If AFib is symptomatic, so that's the important highlight here, if you have symptomatic AFib, we want to talk to you about medicines and or a procedure called an ablation to try to treat it. And AFib increases your stroke risk, so we have to figure out whether or not you should be on a blood thinner to reduce your stroke risk. So any questions about the first part of the talk? The second part, I'm going to focus more on the stroke risk. Yes?
Where does cardioversion play into that?
Yeah, so where does cardioversion come into atrial fibrillation? That's a great question. So if you have AFib that's paroxysmal where it comes and goes, you don't need a cardioversion because you're cardioverting yourself. The time you consider a cardioversion is if you're in persistent AFib, if you're in AFib that lasts for months at a time. Then we got to do something to perturb the rhythm to get you back into normal rhythm. Another time I will consider it is if I'm meeting someone for the first time who has AFib and they tell me they feel fine. They say, I feel great, I can do everything I want. I say, well, let's really see. And then we cardiovert the patient and they say, you know what, I actually have more energy. I have more reserve. I had no idea that I was feeling this way because I just kind of lived like this for many years. So a cardioversion will be a good, minimally invasive test to see if you have symptomatic AFib or not.
Dr. Lee, we have a question from our
Yeah.
virtual.
Pardon. How long must an irregular, fast heartbeat episode persist to diagnose paroxysmal AFib? That is, when do the occasional benign flutters cross over to AFib?
Sure. So depends on what flutter means. If it's something that the patient is feeling, we have no idea what that flutter means. It could be a skip beat. That has nothing to do with atrial fibrillation. If it's truly a diagnosis called atrial flutter, that is a precursor for AFib, just like a TIA is a precursor for stroke. But the technical definition is 30 seconds of AFib constitutes AFib.
Can I ask you something?
Mm-hmm.
I didn't understand, when you were talking before, was that where you shock the heart back into, try and shock it back into rhythm?
The cardioversion is where you do the paddles to shock back into a normal rhythm. So that's done in the hospital side with anesthesia, and it's a very, very safe procedure. You do have to be on a blood thinner.
How successful?
It's essentially 99% successful the moment of the cardioversion. The problem is you may be back in atrial fibrillation as soon as you open your car door. Yeah. So it is also a trial to see what type of AFib you have. If your AFib won't even cardiovert, or you get atrial fibrillation as soon as you walk and go to your car, that tells me that your AFib is really advanced. But you may get years of benefit. Some people, one cardioversion, they're free of the AFib for many years. So we may be catching it early on.
So if you do an ablation, can you get off blood thinners? No.
So blood thinners is, oh, that's a great, yes. So the question was, if you get an ablation, can you come off of blood thinners? The answer is no. The book answer is to stay on blood thinners lifelong if you have certain risk factors. And that's because we don't use the word cure for AFib. AFib is always threatening to come back. And because of that, you may have AFib after an ablation that only occurs while you're sleeping, so you're not aware of it. You may have AFib that lasts only 29 seconds, you're not aware of it. There's a lot of reasons. So as of now, the recommendation is to stay on it. So we never do an ablation to get someone off of blood thinners. It's purely for symptoms. Did you have a question?
What is that procedure that you said shock? what exactly do you do when you go to the hospital?
Yeah, so the question is, what do you do in a cardioversion, or how does it look? So we put paddles, or those patches, on the front and the back of the heart. It's sort of like a defibrillator that you see on TV. So it's a controlled cardioversion, and we time it so that we're resetting the heart on purpose, essentially. So we give it a jolt.
So you give it like a jolt.
We're giving an electrical jolt so that your normal rhythm can fire through again.
So in other words, if you do that, it might get to where your heart will almost go back to normal.
Yeah, so I would say 99% of the time you will be in normal rhythm. We just don't know how long you'll stay in a normal rhythm. So it's not a cure, it's a Band-Aid approach. But it's a good initial approach because it's not invasive. Mm-hmm. Can it make it worse? It won't make the AFib worse. It may reveal some things about your heart though. Some people who've had AFib for too long, once we cardiovert them, their normal rhythm is too slow. So we may trade one rhythm for another problematic rhythm. And then for a slow heart rhythm, you might need a pacemaker, but that's a different conversation. Yeah.
So on this paddle that they use, this is a 2B thing.
Mm-hmm.
They do it and they go, okay, up it, right? So how severe of a procedure can you go to?
Yeah, so the question is how much you can amplify the cardioversion or how intense you can do it. So the rhythms that you see on TV are a completely different rhythm. That's meaning it's a ventricular rhythm. So what you see on TV are patients who are dropping dead, who are in cardiac arrest. That's for ventricular fibrillation, ventricular tachycardia. So rhythms from the bottom of the heart are life-threatening. So when we had that earlier slide about AFib is not life-threatening, there are rhythms that are. Anything ventricular, the bottom of the heart, usually is related to a heart attack. Whereas atrial fibrillation is a safe rhythm when properly treated. So yeah, you will never see on TV a cardioversion for AFib. That'll be a very high-level show. Yeah. All right, so let's talk about, one more question there, yeah.
On the exercise and weight loss preventative
Mm-hmm.
measures, is that more effective in the early stages versus later stages, or do you think,
Yes, early stages, because by the time you have advanced AFib, you really can't reverse that process. You want to start early, and actually the newest guidelines just came out. So the Heart Society came out last month showing that now AFib is a lifelong process. So now they are recommending exercise, sleep studies for patients even without AFib to prevent it from happening. So now it is a healthy lifestyle, which is very relevant to our talk today. So the Watchman is not a watch or it's not about a man, but it's a device that we implant to potentially get patients off of blood thinners who are not good candidates for lifelong blood thinners, and also protecting them from a stroke. So let's just get into the reason why it's important. So this is the left atrium, and this structure should not be there. This is a clot or thrombus. So everybody here has a structure in the heart called the appendage. We're all born with it. It's an embryonic remnant. But in patients with AFib, you see this kind of swirling motion too. You just play that one more time, this clip. I guess I could just go back and forth too, huh? Let's try that. There we go. But yeah, there was a swirling motion here. So when you have AFib, your blood is not being pumped efficiently, so you get stasis of blood, you get pooling of blood. If that pooling is too severe, you're going to form a clot, especially in the part of the heart called the appendage that does not contract. So areas that are contracting nicely have less chance of forming a clot. But the appendage is a structure that does not contract. And so you get AFib, which is already inefficient, and then you get pooling of blood in the structure called the appendage, then you can get this large thrombus. If this thrombus just stays here, that's not a problem. The concern is that this thrombus can flick off, go to the ventricle, and then go to the vessels to the brain. And that would be an embolic stroke. Embolic means it came from somewhere else. So anybody who's had what we call a cryptogenic stroke, or a stroke where, that's a fancy word for saying we don't know where the stroke came from after all the tests that you get, then 30% of the time it's due to atrial fibrillation. So if you've had a stroke and we don't know why you had a stroke, we should look very, very hard for AFib. You may have early AFib that's only happening a few times a year, so you're going to miss it in your doctor's office. So you can see why patients with AFib need to be on blood thinners, is to prevent this very scenario. And the strokes that AFib patients get are very severe because the clot will dislodge to all the vessels in the brain. Whereas if you have carotid disease, it's just affecting one vessel. It's not a hemorrhagic stroke. A hemorrhagic stroke is a bloody stroke. It's related to bursting of the blood vessels. So we're talking about ischemic stroke. That's more related to lack of oxygen. So this is like a heart attack in the brain. Everything in the body is a continuum. If you got a blockage in the legs, that's called peripheral vascular disease. Blockage in the heart, that's called a heart attack. Blockage in the brain, it's called a stroke. It's all the same thing. And so those are risk factors. If you had a stroke, you probably should look for heart blockage and leg blockage too, just as an aside. So this area here called the appendage accounts for more than 95% of clot formation. So this is a very important area of the heart. So in order to prevent that thrombus from forming, we want to place you on blood thinners. So this is a very encouraging chart in that the salmon color or the red color here represents Coumadin usage. That's the tried and true medication. So even as of 10 to 20 years ago, it would have been the most popular option. And as you see that as we come into the 2010s and 2020s, these other medications are becoming more prominent. So these are the Pradaxas, the Xareltos, the Eliquises. So that's great. The problem is, you see the sky blue area? We got 40% of patients who should be on a blood thinner are not taking blood thinners. So 40% of patients with AFib are at high risk of stroke because they choose not to take blood thinners. So these are all the generic names of very popular blood thinners. In the trials, there's a very similar discontinuation rate. Patients 20 to 25% of the time just cannot take blood thinners long term. There's also a 2 to 3% bleeding rate per year. So it's not a trivial thing. Bleeding is a real phenomenon. So you can see why that patients don't want to take it. There's other issues too. These drugs can be very expensive. There's no generic for Xarelto or Eliquis. Patients say they're paying $500 for this prescription. Coumadin is the oldest one. There is a generic available, but you have to watch what you eat. You got to get blood draws on a regular basis to make sure your Coumadin levels are under control.
When you talk about major blood problems, does that mean like when you cut your finger or something, you bleed a lot?
So in the trials, they're looking for major bleeding, so GI bleeding, bleeding in the brain, things of that sort. Not kind of day-to-day bruising and gum bleeding, hemorrhoids. That'll be different. That'll be minor bleeding. So this is the calculator that I'm using in my head whenever I meet someone with atrial fibrillation. We call it the CHAS-VASc score. And as you see, so C stands for congestive heart failure, H for hypertension or high blood pressure, age greater than 65 is 1 point, diabetes is 1 point, stroke is 2 points. So stroke is a big risk factor. Vascular, meaning do you have peripheral vascular disease or aortic issues? Age greater than 75 is 2 points. So if you're 75 or above, we give you 2 points. And then sex category, so if you're a woman, that's a point, believe it or not. So this calculator is relevant only if you have AFib. Not if you don't have AFib, you could stop calculating for yourself right now. So if you have AFib, you should calculate. And if your score is 2 or greater, that's where we recommend anticoagulation or medicines like Xarelto, Eliquis. That's because if you have a score of 2 or greater, your risk of stroke is 2% per year. So it's cumulative. If you live another 10 years, that's 20% risk. If you live 20 years, 40%. You can see how these numbers will balloon, and it's a probability. During that time, if you have, let's say, a 50% risk of stroke, you're really at a coin flip of having a stroke or not. If your score was 5, your annual risk is 5 to 6% per year. If your score was 1, we give the patient the option to be on blood thinners or not, and that's because blood thinners have problems too. The bleeding rate is 2 to 3%. So we don't want to give you a problem when the bleeding risk is higher than the stroke risk, if your score is 1 or 0. But if your score is 2 or above, the bleeding risk and stroke risk is either equivalent or the stroke risk is going to be higher. So the Watchman is potentially a solution in folks who have a need to be on blood thinners because their CHA2DS2-VASc score is 2 or above, but they're not good long-term candidates for blood thinners, whether they have GI bleed history, brain bleed, severe nosebleeds, gum bleeding, whatever it is. In that patient, we may not be doing justice for them if we're recommending blood thinners if they can't tolerate it, if they're bleeding all the time. Their lifestyle is affected. So the Watchman is a device, it's a one-time procedure, a structural procedure where we deploy this parachute-like structure into the appendage. What happens is, even though blood may be swirling here, it can't enter this space anymore. So this structure where 95% of blood clots form is eliminated essentially. We can take you off the blood thinners while minimizing your stroke risk. So this is a relatively new procedure, I'd say mainstream over the past 5 years or so. But I don't want you to lose sight of the fact that the mainstay, the cornerstone of therapy for stroke prevention is still a blood thinner. Right now in 2024, we have no randomized trial to prove whether or not the Watchman is equivalent to lifelong blood thinners. It's probably just as good. We just don't have the data to say that for sure. Mm-hmm.
What's your anecdotal experience with them?
Anecdotal.
What's the question?
So the question is, what's my anecdotal experience with the Watchman and stroke prevention? I'd say it's very good. For me, it's become so good that in the past, when I first started doing this, I would reserve it for people with history of major bleeding. Now I'll be open to doing it if the patient just says, I really want to get off of blood thinners. Because if the patient is saying that, there's a very good likelihood they're going to be in that sky blue area of that chart that I showed you earlier, where they don't take the blood thinners routinely, and then their stroke risk is high. So I'd rather have them minimize their stroke risk with the procedure rather than not take blood thinners and put them at risk for a stroke. There's the animation here. It's a few minutes long. I can walk you through it. We go from the right groin, put a wire into the heart, goes into the right side of the heart. Remember, AFib is on the left side of the heart. Here's the appendage. That's the Watchman. So how do we get there? All of our tools end up on the right side. There's a thin structure here called a fossa. We're going to use this to poke across. It sounds awful, but that hole naturally seals off in a few months. It's a maneuver that I personally do more than 200 times a year for my AFib ablations and the Watchmans. You got different shapes, right? Broccoli, the chicken wing. The most desirable is a windsock because it's just a straight shot. You know, the appendage is like fingerprint. Everybody's appendage is different. I've noticed anecdotally that the vegans always have chicken wings and the meat eaters always have broccoli. But we deploy this little pigtail. We're going to puff contrast to size the Watchman and see what the shape is. And then we're going to deploy the device at the os, meaning the entrance of the appendage. So you're going to see it deployed here, and then we size it. There's anchors here that engage the tissue. We tug it to make sure it's not going to dislodge. And then we puff contrast and nothing is entering the appendage. So this is one of the few procedures that we don't have to advertise. Patients, and you can see here over the course of a few months, your body forms tissue around it. That's called endothelialization, and this is when the Watchman becomes a part of your body. By this point, we can take you off of blood thinners. When it's exposed, when it was still that mesh shape, ironically, you still have to be on a blood thinner. So to do a Watchman, you have to be able to take blood thinners short term until this happens. and then we can take you off.
So what's that material made of?
It's a nitinol.
Huh?
It's a nitinol frame. Nitinol.
How long has it been around?
Mainstream about 5 to 6 years. Yeah. Yes, in the back. Huh? No, there's no batteries. It's a physical structure that we implant. There's 5 sizes, and we tailor it to the patient's anatomy. Yes.
I had a stroke, but I didn't know I had it. I found out from my MRI that I had one. And so he put me on 81 milligram aspirin. Should I be on a blood thinner too?
So that's a good question. You've had a stroke. Do you have AFib? So he's had a stroke. No history of AFib. Should he be on a blood thinner like Xarelto? Not until you have AFib. Not until you have AFib. So aspirin is okay. But one misconception is aspirin is not a blood thinner. So the reason why you bleed though is that it prevents the platelets from forming. So if you cut yourself, we wait for a scab to form. What aspirin does, it delays the scab formation. It doesn't actually thin the blood out. It just prevents the scab from forming so that you look like you're bleeding. Whereas for a blood clot, you gotta thin the blood out. So a lot of patients say, I just want to be on an aspirin. And to tell them, it's not a true blood thinner. Yeah. But for certain conditions, you have to be on an aspirin. Like if you had a stent, you should be on an aspirin. If you had a stroke without AFib, you should be on an aspirin.
Is there a risk factor to doing this? I mean, all of them are.
Any procedure can potentially have complications, of course. Our success rate has been 98%. The reason why the Watchman wouldn't work is if you had an appendage that was just not accommodating for the current sizes of the Watchman. Your appendage might be too big, it might be an unusual shape that won't allow a snug fit. You don't want any gaps in the device, you don't want any protruding shoulders on that device, so you have to be a suitable candidate.
And you don't know that until you're actually doing it.
Yeah, we do an ultrasound of the heart to see if you're a candidate for this procedure.
Dr. Lee,
Yes.
maybe do the questions.
At the end,
Oh, that's a
just
great
so-
point, yeah.
Perfect.
I think there's a lot of questions related to this. Why don't we move on? So these are classic trials, Protect AF, CAT, Prevail. The names are not important. Basically showing that with all these trials, the success rate is very high. The green bar represents real world data. So for the past 5 to 7 years, every hospital, after every patient who gets a Watchman, has to input their success rate, complications, and using real life patients, the real life data shows that there's a 98% success rate. So it's a very positive solution, and that's why I've changed my practice to include lifestyle indications with your question earlier about what's my take on it. In the beginning, I reserved it truly for the major bleeders. So who would be a good candidate? So patients who have drug interactions. Some drugs just do not interact well with blood thinners. For example, if you are on an aspirin for a stent, some people are aspirin and Plavix, and now you have AFib, you have to be on another blood thinner like Eliquis, then you're on 3 potentially blood thinning regimens. That could be a very, very potentially dangerous combination. So for those patients, we would consider it. If you had a history of major bleeding like GI bleed, brain bleed, we would consider it. If we feel like you might be at risk for falls because your balance is off, we don't want you to hit your noggin on a blood thinner. That's the most feared kind of complication with a blood thinner because your brain is a closed space. If you have bleeding in there, it can be a very serious issue. If you have renal disease, then you could be at risk for bleeding because your platelets are not as good. If you're non-compliant, meaning you don't take the blood thinners for whatever reason, you're just not good about taking twice daily medicines, or you just feel like the cost is prohibitive, can be a lot of different reasons why someone doesn't want to take it. Or lifestyle and occupation, if you like gardening every day, you're cutting yourself. If you are a police officer or you're a football player, for example, you don't want to be on a blood thinner. So there's many, many different reasons nowadays. This is just showing that we did 100 in 2022, and since then we probably did another 100, 150. So it's just a very, very popular procedure, and it's what I was going to say earlier is that we don't even have to advertise for this because patients have that tangible desire to be off blood thinners. So this is one of the procedures that's more word of mouth. Somebody gets it, tells their friend with AFib, saying, you know what, you should consider this. So it's a procedure that's becoming very popular lately. So to summarize the Watchman part, in patients with AFib, the left atrial appendage creates a substrate for clot formation, and if that clot dislodges to the brain, a stroke results. So we use that calculation called the CHAS-VASc score, and if your score is 2 or greater, you need to seriously consider being on a blood thinner. And in patients who are not suitable candidates for lifelong blood thinners, then the Watchman may be a good option. So this is the end of my slide. So if you have any questions, I'm happy to answer. Yeah, go ahead.
I just have a question in general then, as a patient, you would only have one appendage, or would you have more than one?
Just one, yeah. One too many, yeah.
So what's better, the ablation or the watch?
So yeah, so the question is, what's better, the ablation or the Watchman? Like we said, it's just two separate reasons. The ablation is for symptoms. So the Watchman will not make you feel better. It's not going to fix your shortness of breath. It's not going to address the AFib. Your AFib is still going to be there. It's truly to get you off of blood thinners. And the ablation is to try to get rid of the rhythm. Mm-hmm. In the back over there, yes?
And does that appendage have any purpose overall? I mean, is it like an appendix, you just don't need it?
Yeah, that's a great analogy. It's just like the appendix. It serves no purpose but causing issues. Yeah. Yes, so the question is, are these procedures, including the ablation and Watchman, experimental, or is it covered by Medicare or insurance plans? Most insurance plans cover both procedures nowadays. Medicare especially, yes. And then some of the commercial plans used to consider the Watchman experimental, but now even with the latest guidelines as of a month ago, they've increased the class of indication. Now it's what we call a 2B indication, so it's pretty strong recommendation to do it in folks with any sort of bleeding issues or lifestyle issues. Yeah.
Dr. Lee, we've got a question from our virtual attendees. One said, please discuss the relative risk of anticoagulation contributing to brain bleed versus stroke versus clot, stroke without anticoagulation.
That's a great question. So is there a potential downside in starting blood thinners? Can it cause problems like a hemorrhagic stroke? Can it cause a brain bleed? It can. The explanation that I give patients is the blood thinner will never cause the bleeding, but you will bleed if you have a reason to bleed. So if you start Eliquis, that's one of the blood thinners. If you have an ulcer that was never diagnosed, it'll reveal the ulcer. If you have hemorrhoids, it's going to make your hemorrhoids worse. If you have an aneurysm in your brain, for example, that was never diagnosed, yes, a blood thinner could potentially make that aneurysm more friable and prone to burst. So in the absence of any of that, can the blood thinner alone cause issues? Exceedingly small. So it's more of, do you have risk factors where a blood thinner can contribute to making things worse? That's the question. Mm-hmm.
We have one. There's another one. We have a guest who is currently taking flecainide along with other medications. The flecainide has been keeping her or him AFib free for a few years now. Do medications eventually stop working?
Another good question. Medications are more of a Band-Aid approach. In the beginning stages, so if you're in paroxysmal AFib, the medications can work for many, many years. So analogy I would give is, you got a painting that you hammer into the wall. That nail is basically keeping the picture there. If you got a heavy picture, though, it's going to constantly threaten to weaken that nail. And eventually, it's just going to fall. And that's the same thing with a medication like flecainide. The AFib is threatening all the time, all the time, all the time. Eventually, the heart stretches, gets bigger, the flecainide will fail. Mm-hmm.
What about for persistent or chronic AFib? Is the treatment usually just stroke risk reduction, blood thinners?
or is ablation used at this time as well?
It depends on how chronic the AFib is. We've treated anywhere from 10 to 15-year duration AFib. Those are very challenging because the heart's extremely large. For those patients, I might even offer them the next step of ablation, where we call it the hybrid approach, where it's a combination of a cardiothoracic surgeon and myself offering the procedure. But that's a separate conversation. I think everybody can be considered for it. I think nowadays it's pretty rare that we give up. There was another bucket of AFib called permanent AFib. That's where we just say, we're not going to do anything. We're not going to give them medicine. We're not going to try ablation. We're not going to try cardioversion. Only thing we're going to do is put them on a blood thinner for stroke prevention. But for symptoms, for the AFib, we're going to leave it alone. That used to be very common. But I think nowadays we're trying to treat it as best we can because we're getting so much data that AFib is just bad. Even dementia, that is more of a new finding over the past few years.
How can you tell if you have an atrial flutter versus or that you might have going to atrial fib?
Yeah, how do you tell if you have a flutter or AFib? From a patient standpoint, all the rhythms feel exactly the same. So you will not know if you have a flutter, AFib, atrial tachycardia, SVT. These are all rhythms that are out there. The only way to know is through an EKG. So I wouldn't know either if I felt your pulse. I would know that you have AFib, but I wouldn't be able to distinguish those.
But I thought EKG was not that definitive unless you have a longer EKG, a quick EKG reading. I thought wasn't sufficient.
Oh, if you truly have the rhythm while we're doing the EKG, it is definitive. Yeah. Yes. Oh, do you get more fluid in the heart if you have AFib? If you already have heart failure, AFib will make the heart failure worse. So we didn't talk about that today, but there is a category of patients with AFib. That's people with heart failure. Even without symptoms, the recommendation is to try to fix the AFib. There is a mortality benefit. Patients live longer and less readmission rate. They have less hospitalizations. So patients with heart failure with AFib, we are aggressive in treating the AFib. Yes?
I was wondering, I have a bunch of questions, but if I go to my primary doctor and I ask him all these things, can he answer them, or do we need to go to a person like you who's a specialist?
It depends on the cardiologist too. A lot of non-electrical cardiologists may not be able to give you the full menu. Whereas an electrical doctor will give you the appetizer, the entree, and the dessert. Whereas, it's just the same thing. If you come to me for a heart attack, I'm not gonna give you the full menu. So I will refer you to someone that can answer all those questions. So if you come to me and you're my patient, you have a heart blockage, I would refer you to my colleague who can do a heart blockage procedure. And so I think, personally, if you truly have the rhythm, you should go see an electrical cardiologist.
Okay, that's in the heart.
There's three major arteries that causes angina. So that'll be a different conversation. But the main, there's bundles in the ventricle. They call it a right bundle and a left bundle. It doesn't affect that. So the atrial fibrillation affects the top of the heart, and the bottom is a bystander. The bottom is affected because it's just passively receiving those signals. But that's more of a pacemaker issue, the bundles being a problem. Angina usually means heart blockage, but for some people, AFib symptoms can reflect as chest pain. So if you have chest pain, it is a difficult workup. We're probably going to still look for heart blockage first. In the back there. Yeah, so that's a good question. So someone's on aspirin who has AFib who wants to get a Watchman, I would. Right. Yeah, so if someone gets a Watchman, I'll stop the aspirin and put them on something like an Eliquis until the body forms that tissue around the device. And then after that point, 6 months later, you could be on an aspirin alone. Mm-hmm.
Speaking of the Watchman, you mentioned
98% success rate. What about those 2%? And
Yeah.
do they usually have a stroke, or how does that?
Yeah, no, great question. So any procedure, you could have complication for sure, but in the grand scheme of things, it's a very safe procedure. I would quote you a less than 0.5% risk of a major complication. So we've done more than 200 of these. So the two major complications was, one, we had bleeding around the heart sac, and that's because the Watchman has those anchors that engage the appendage, and those anchors can sometimes poke through the appendage and cause bleeding around the heart sac. In that situation, we recognize it right away. We drain the excess blood. The other is the Watchman, we want it to be flush and not move. One of the Watchmans moved, so we had to retrieve that. And there are ways of figuring out how to make sure that Watchman is secure or not. That particular patient really desired to get off a blood thinner, so we did our best to try to find a solution for them. But it ended up moving, so we just had to retrieve it.
And at that point right there, you say you go in a size for the Watchman. So is that going in twice, or you go in once and sizing?
Yeah, we make measurements using imaging. So we have imaging studies to see which size would be the best for that particular patient.
Without going back in?
Without going back in, yeah. So even before we do the procedure, we'll do an image of the heart to see if the appendage looks like a appropriate candidate. Yeah, we don't want to go in there and guess, so we make the measurements beforehand.
The Watchman procedure is longer or about the same?
It's very short. So if you have a straightforward windsock anatomy, it can be done as quickly as 10-15 minutes. Yeah. And in a more challenging anatomy, maybe up to an hour, but it's relatively quick. Mm-hmm. Yes?
Other than the blood thinners, what other medications are involved in treating this?
So yes, blood thinners are for stroke prevention, but for symptoms, if you didn't want to do an ablation, and let's say you wanted to try to control the rhythm, there's a class of medicines called AV nodal agents. That's just to slow the heart rate down. So beta blockers, I'm sure you've heard of. Calcium channel blockers. Those are medicines to slow the heart rate down. And then there's another category called antiarrhythmics, designed to try to prevent the rhythm. So those are available as well. But all of those are more of a Band-Aid approach.
Dr. Lee, we had a question. Are POTS and AFib similar?
They are not similar.
Okay.
No, POTS is a different diagnosis.
And then what about any foods or supplements that can kind of trigger AFib? You mentioned diet and whatnot, but is there anything that could just...
No, the common triggers are alcohol. Yeah. Alcohol for sure is, if you have a propensity for AFib, that will be a trigger. Yes.
Is age or how long you've had AFib a factor in the success of the outcome of ablation?
The age itself is not an issue. The duration of the AFib is. So even if you were 90 years old, if you had paroxysmal AFib and you're a robust 90-year-old, we would give you all the options. If you were a 60-year-old and you had AFib that's been present for 10 years, that would be a much more difficult conversation.
So what was the, like 2 years, would that be a long?
That you would, technically you are persistent AFib if you have 2 years of AFib, but nowadays that would be treatable. We wouldn't deny that patient. Right. Mm-hmm. I think, yeah, you've had your hand up.
Is the Watchman permanent, or does it ever have to be replaced after so many years?
It's a permanent solution if we get the size right the first time. Mm-hmm.
What is a permanent solution?
Is a Watchman a permanent solution, or is it something that you have to replace? No, it's the goal is for it to be done in one try. Mm-hmm. Yes.
So you have these self-diagnosis patients. He finally goes and sees you. And is that AFib? How can you tell how long he's had it?
So the question is, if a patient with AFib sees us, Can we determine how long they've been in AFib? It really is hard to know. We would go more by symptoms in that situation. If that patient can reliably say, whenever I'm in AFib, I feel tired and short of breath, then we ask them to think back, how long have you felt that way? And that patient's usually pretty reliable. And they say, I felt like this for 5 years. You probably had AFib for 5 years. Yeah.
Is this a patient you might know, sir?
Are there any particular nutrients, they're using or anything like type of thing that might help it? And then you mentioned coffee was, they're not sure with coffee how they decaf, does that make a difference? And the last thing is AI, you think coming around the corner that's going to be earth-shaking.
Great. So nutrients, there's really no pill or vitamin that's going to magically alter the atrial fibrillation, unfortunately. I would say it's more that lifestyle modification. It's just a tried and true for any condition, the exercise, stress reduction, sleep apnea, alcohol reduction, tobacco reduction. And caffeine, we really don't know. The newest guidelines actually say caffeine may not be a risk factor, so I got very excited. So I am drinking 2 cups nowadays. I don't think so. And AI is going to infiltrate every part of medicine. So it'll probably help with atrial fibrillation detection, our procedures as well.
Thank you.
In the back, yes.
Yes, I was up for a couple of surgeries, and I have the atrial fibrillation. I also have I've had a stroke. So there was a fight between my surgeon and the cardiologist, who makes the decision to get off the blood thinner I'm on, Eliquis. So if I'm off the blood thinner for 3 days, then I have a chance of another stroke doing surgery. So there was a balance there. So I elected not to have the surgery for right now.
I see. I think that's more of a nuanced question. Maybe we could talk about that offline, because I think there's a lot of factors I need to tease out before I could answer that question. Yeah. Over there.
When you say things are a trigger, how does it trigger? Like you said, alcohol or whatever. What's happening to make it trigger?
If you've drank a cup of wine tonight, a glass of wine, the next day, all of us, our heart rates will elevate. Even the next day, you're just gonna kind of feel that revved or kind of a bounding sensation. There's receptors in the heart that react to alcohol, and you do it long enough, there can be a certain time where that transitions to atrial fibrillation. It thickens the heart, it revs up the heart, so you constantly put that heart through that scenario. It's just like sleep apnea. Every time you sleep, take minutes of low oxygen, you're just threatening it, putting more stress on the heart, and that's the same thing with alcohol too.
What type of, do you have this conscious sedation when you do this, Watchman, or is it?
We do general anesthesia because we use an ultrasound through the mouth to take pictures of the heart.
So it's a
General anesthesia. Yes.
Can anyone go to see you, or do they need a referral from a cardiologist, or?
It's the same as any health. It depends on what your health plan is. Yeah. I think a lot of these things, yes, if you have interest in learning more about it, any rhythm issue, and the EP will definitely be able to help. A lot of these procedures, believe it or not, are still considered last resort by the community. So even doctors will say, the ablation is ineffective. You should try medicines first. You should try cardioversion first. But remember that slide earlier, your AFib can transition very quickly. By the time you try all those methods, I may see you when you're in persistent AFib, and that I would say would be a lost opportunity. Because if you just chose to see me right away, then I would meet you in the early stage AFib, and your success rate for long-term maintenance is much higher.
So what would your basic study, your baseline for a patient who comes to you?
We go by symptoms. So once we determine you have AFib, patient goes, okay, I'm able to see that these are my symptoms when I'm in AFib. They'll say, maybe I'll purchase an Apple Watch. I might want that chip. Let's see what my AFib burden is. And if it's 1% 1 year and then it transitions to 10 to 15%, they go, wow, I'm feeling 10% worse now. I want to seriously consider some of these other options.
Well, we definitely had the opportunity to educate ourselves. Thank you, Dr.
Thank you.
I mean, how many people are walking out with 5 new pieces of information? All right. 3? All right. Well, more than 5, yeah. So we just want to say thank you, Dr. Lee,
Thank you, yeah.
thank you all for coming. Really appreciate it. And please, Dr. Lee might be around for just a little bit. But thank you very much again for coming, and look for some more events coming up in March.
All right.
Thank you.